Hello, everyone. I am so excited. My name is Jacob Avila. And before we get started with our first episode, or the first of this season, I know there's been like a bunch of other image review seminars in the past, but for this kind of thing that we're going to be doing moving forward on a regular basis, we just have a couple of little housekeeping things that we have to get kind of out of the way. I'd like to walk you through a couple of different features that are available to you during this webinar. Now, if you look on the right-hand side of your screen, you'll see three different engagement widgets. You'll see a QA widget, you'll see a poll widget, and you'll see a survey widget. During the webinar, you can submit questions via the QA widget. Now, if your question isn't answered because we are unable to get to it, please don't despair. You can always reach out to us at imagereview@butterflynetinc.com, and we will follow up with you with whatever specific question that we were unable to answer. Now, we are also going to be asking you questions associated with the clips we will be discussing. Open the polls widget to participate throughout the webinar. We really want to know what your ideas of these images are moving forward. Lastly, at the end of the webinar, we really would love to hear your feedback. Personally, I would. I know Peter would. I know everybody at Butterfly would, because we really want to make this engaging for you. We have so much good content. We have so many good images and clips, so many good stories, and we want to give it to you all in a manner in which it's the best for you. So please let us know. Use that survey widget to provide feedback on how we can improve moving forward. Now, let's begin. I, as I mentioned, am Jacob Avila. I'm the Vice President of Clinical Education here at Butterfly. I am joined by Dr. Peter Weimersheimer. I met Peter quite a few years ago in some other endeavors, and it's just, Peter, we're just meant to be together, man. We're both VPs at Butterfly. You're the Vice President of Clinical Implementation. I'm clinical education, and I get to talk to you like every day. It's like a dream come true for me. How are you, Peter?
I'm doing great. Yeah, I think this was 2014 that we first, so we're getting on a decade anniversary soon. So yes,
yeah,
absolutely. Been great.
I already bought you flowers and chocolate, but it's not quite the 10-year anniversary yet. So we'll have to wait till 2024.
As long as it's dark chocolate.
Fair enough. All right, let's get started. You ready, Peter? Should we get started?
I'm looking forward to it.
Right on. All right. So what we're going to do is basically go through some clips and just kind of chat about them, just like we do with our residents when we do image review where we work. All right, Peter, what do we have here? Let's start off with just an easy cardiac view here.
Yeah, this is my favorite cardiac view. This is an apical 4-chamber view. It's in a cardiology convention. You can see the marker towards the right side of the screen. And what is so great about this view is you get to see a lot of information pretty quickly about the heart. So there's chambers. So there's the LV and the RV. So the LV on the right, the RV on the left, and also the LA and RA. And so you get to see those relative chamber sizes. What's really nice about this image as well is you can see both valves. And what's important about an apical 4 is to really make assessments about chamber size or even relative function. Dialing those valves in and getting them both in view really has value for being confident in those decisions that you make. So really nice view here.
Agreed. But should we compare it? So there's something wrong with this heart, right? Or abnormal. Now, what I want to do is I want to kind of pull in on the left side of the screen. We have a relatively normal apical 4-chamber view. On the right, I'll tell you the first one that we showed is less normal. Now, on the left, I will fully concede that it's not the best apical 4-chamber view because I'm really kind of missing out on the entire size of the left atrium down here, which is on the right side of the screen. But for the most part, it's a good, I think, apical 4-chamber view. Now, Peter, when we compare the image on the left with the image on the right, what's the big thing that kind of sticks out?
Well, what sticks out is that the LV on the right side isn't squeezing as well as the LV on the right and on the left. And even important as you talked about whether it's the best view or not, one thing that's so important about using clinical ultrasound at the bedside for clinical decision making is you don't necessarily get the best view. but you get enough information to make a clinical decision. So just using the reference on the left of being normal, looking at the view on the right, that I'm concerned that potentially the patient I'm seeing is presenting, and one of the reasons they're presenting, or part of their symptoms, that their LV isn't working as well as I would expect from the other side.
Yeah, no, brilliant. That's a very good point. And that's one of the things that I actually like tell anytime I'm doing image review. It's one of the things that I mention very frequently, is the fact that the images that we often show with lectures, and honestly, I'm trying to kind of move away from that, are just the most perfect, most pristine, nothing wrong with them views. But in real life, right, Peter, it's a little rare for us to get that like perfect view, right? I mean, we basically have a limited amount of information. We do the best we can with it.
I never get a bad view, Jacob.
I need you to teach me then. I need you to instruct me on how to get like perfect views every single time.
The important part as we're going through these is to get the information from the view that we can to make a clinical decision and to be confident in that clinical decision in management. So one thing, Jacob, I was looking at this image on the right, there's something else that's really interesting. If I look towards the septum, I wonder if you've been noticing that.
Oh, let me look. You're right, man. I mean, looking at this view, it's definitely, I mean, I can see, you know, one of the markers that we look at are, you know, how well the walls are squeezing on the LV. And I'm seeing that the LV it's pretty big. The left atrium is kind of on the big side too. And this is all comparing it over to the right side of the heart. So looking at this side over here, it's all kind of big. We don't see a lot of motion, you know, overall. And I see that the right side of the heart looks, I don't know, pretty vigorous over here, right? Like it's like in, you know, distress almost. But here's what's like kind of like sticking out to me a little bit. Now, one of our surrogate markers for if a LV is functioning well is something called the EPSS, or the E-point septal shortening. So if we look over here on this left side of the screen, we look at, and typically, to be clear, that's done on a parasternal long axis view, but you can do it on the apical 4. Let's look at this right here, this more medial leaflet of the mitral valve, and we can see that it's coming up and it's getting pretty close to the septum, if not touching it. So I would say a low EPSS. We could always hit freeze and actually measure it. And then when I look over here, I see that it's really, I mean, it's getting to about like halfway, right? So this EPSS is quite a bit larger, right? Now, looking at that specifically, I'm looking at this and I look over at the septum over here, and I notice that the septum is really not, I mean, if we compare the contraction, so basically how thick and skinny the septum is getting, it's a bit different from what's happening in the apex and what's happening in the lateral wall. Like we're seeing good contraction and relaxation of the wall at the apex and the lateral wall. But you know what? Looking at the septum, man, it's really not moving the same as the apex and the lateral wall. What does that mean?
Well, it means that there's, at least at some point in time, there's been damage to the myocardium there. And you can use the location of where that wall motion is off to even make a guesstimate about which vessel of the heart has been damaged, or currently, if this patient's presenting now with chest pain and potentially EKG changes, this would be a diagnostic for the exact cause of the chest pain as well.
Wow, that's insane. So question, I mean, so I hear you, right? But one of the things that I struggle with this is, if I have the EKG, what would the benefit be of knowing where this distribution is? I mean, are there times where you might actually see this before the EKG changes?
Well, any test you do has an error rate. And certainly, I think you and I probably have both experienced someone who's coming in who's had a non-diagnostic EKG, even with subtle changes that might be indicative of a myocardial infarction. And we've gone to do a bedside echo, and there's been the wall motion abnormalities. That person had patients go to the cath lab based on the echo with a normal EKG because of those wall motion abnormalities. So it's always nice to have as much information as you have about any patient in front of you. And sometimes one of the tests isn't as good as you think it should be, or it isn't as good as it's supposed to be, and you have another answer. So in this case, here's an answer.
Yeah. I mean, one of the times that I think this is the most useful is actually in a rest or peri-rest situation. I mean, when you have chest compressions, you have going on, you have 10 seconds for pulse check. Getting an EKG is literally impossible, right? And so this would be like a good way if you're in the middle of a pulse check, you get ROSC. and then you see this on like a previously healthy person, I mean, that would be enough for me to, want to fire the cath lab. So I think that knowing this, even though we have EKGs at our disposal, is great, because this is, like you said, another data point. Now, one thing that I wanted to kind of show, it's pretty sweet. I've actually, so I still work part-time clinically. I still am seeing patients, and I'm noticing that sometimes I'm not getting the best view with just like the basic cardiac setting. And it happens. Sometimes we can have the most high-tech advanced machine and still be completely unable to get views. But one of the things that we've been doing a lot more is actually using the other settings. So over on the left side, now this is all the same person. This is the same ultrasound, same location, is the just basic kind of cardiac view. And then we have a cardiac deep, which is what I showed you before. And then we even have another setting called cardiac coherence, which really changes the contrast ratio basically of it, and can really help you much more easily, I think, be able to see the walls. And Peter, on this image on the right, the cardiac coherence one, I feel like that one is the one where you can like almost see like a clear line where you see that regional wall motion abnormality, right?
Right. It's, coherence is much more contrasting. I think the point is for all of these is that depending on the patient in front of you, one setting may work a little better. So in this case, it seemed like the deep setting coherence worked better, but there may be another patient where just the regular cardiac setting is going to be the one that's optimal. And also people have personal preference. Coherence is very contrasty. I personally like that a lot. And there are other people who like grayscale. And so what's nice is you're supposed to, or you can adjust your settings depending on your preferences and also the patient in front of you. So you could be, again, more confident in the picture that you're getting and the decision you're making on the patient in front of you.
Yeah, I know. I totally agree with that. And I agree with you with the fact that I mean, there's times where I really like just this, like the less contrasty stuff. And the sorry, my screen went crazy. And then the other time where I don't want it as contrasty. So,
and I think there's a poll question about these slides as well.
Oh, great. So should we talk about the poll question? I guess we'll wait. I mean, it's as soon as we talk about it, we'd love to see your guys' feedback on those poll questions as well. These are all questions that Janet Hoyler and I worked on, and I'm pretty excited to work on them. And look for those, and we'll talk about them as they come up. All right, Peter, on the left side, we have our previous one, the one that we kind of already talked about. Now, the right side, this is kind of like our discussion, right? Our discussion about the fact that our views aren't always perfect, right? I mean, because the one on the left, it's a little on the grainy side, but I'll tell you, when I was kind of going through this, I had a difficult time getting what I wanted without having it high contrast over here. Can you walk me through what we're seeing here on that right side compared to the left side?
Well, if anything, the right side is even grainier, but when I look at the right side, there's something that really stands out, is that now the chamber on the right side of the screen, or the left ventricle, looks relatively appropriate for the size. But then when I look at the chamber to the left side of the screen, that's the RV, and that looks enormous. So again, the point that this image, I'm assuming, is on a patient who is probably dysmic or maybe even unstable in terms of vital signs. And by this image right away, I'm concerned that there is some significant right ventricular dysfunction, potentially a PE or obstructive shock. And just that image immediately is enough to frame how I would think about managing in terms of fluids, pressures, maybe thrombolytics for the case in front of me.
Right. And looking at this clip, and this is RV enlargement, right? Looking at this clip, I mean, we have basically the opposite, right? So we have the LV over here, RV over here, and we see that the LV is actually moving pretty well, whereas the RV isn't, because it's so dilated due to, spoiler alert, it was a big PE. Now, Peter, what if, like, let's say I look at this clip over here, and I accidentally had the abdominal setting on, which brings the probe marker over to this side? Like, how can I make sure that I'm not confusing the right heart with the left heart? Because the treatment for heart failure is dramatically different than the treatment for a massive PE, right?
Absolutely. And I think what's important is just recognizing pattern recognition of how to tell which part of the heart is what, independent of those probe markers, because there's all sorts of ways that those probe markers get messed up. So important pearls are just when you're looking, for instance, on this left side here, you can look and see that for that smaller chamber on the left, the valve is more apical. That's a tricuspid valve.
Right
And
there.
that's just a little more apical than for the chamber on the right. That's the mitral, and that's a little more distal. So that's one key to let a user know that this image has correct orientation. So the LV is on the right, which is normally where you have it. For the picture on the right of the screen with that big RV, again, the question is that just flipped over and the LV is on the wrong side? Every once in a while during the clip, you can see that aortic outflow tract that shows up, right? The aortic outflow tract is coming out of the LV. So that's confirming that the orientation is correct. And this is a big RV and it's not flipped around. So a couple of pearls that you can look at really quickly to just make sure you have the correct orientation.
Yeah, no, that makes sense, and I love that. Now, one of the things,
there's one more thing.
No, go ahead, please.
The clip on the right where you can see that big RV, like right over here, there is right on the top in the RV right here. If I can get this, there is this white line right there.
Oh, yeah,
Can you tell me what that? You know what that line is, right?
Man, can I tell you a funny story, Peter? Like,
I love
so when I was an intern, it was me and Ben Smith, who Ben Smith is like, continues to be a really good friend. He's my mentor. He's the guy who basically got me started on this thing, amongst other people. But when I went to residency, when I was an intern, it was basically like me and him were the ones that like did the ultrasound. So like if he wasn't on shift, I like struggled, right? So the first time that I saw that thing on a patient with, honestly, they had chronic right heart enlargement, I thought it was a clot. It's crazy. So what that is there's like this little hypercook thing basically towards the apex of the RV, and that is the moderator band. And the moderator band, if you don't know, you might actually confuse for a clot, and you don't want to see like clots in transit in patients by any means. And they tend to be a lot more prominent in people who have chronic right heart enlargement. And with that is actually like try to figure out what is the point of that. It's called the moderator band because at first it was kind of thought to maybe like inhibit the RV from expanding too big because it's got such thin walls relative to the LV. And then later on, they kind of found that it actually has some conduction system stuff in it. So it's got some purpose, probably more for the conduction system. But I think the most important purpose for us is the fact that it confuses us.
Well, but the good news is that it's only in the RV and you don't see it in the LV. So one more piece of information to confirm that if you're going to make a clinical decision on the patient in front of you, that if you see the moderator band, that's the RV. So use your decision base. That helps out quite a bit.
Oh man, that's huge. Speaking of which, I just kind of mentioned the first time I saw it is in a patient with chronic RV enlargement. One of the things that is pretty important when looking at right heart enlargement is it acute or is it chronic? Is this a new problem that we have to deal with today? Or is this right heart enlargement something that is due to, 30 years of smoking? Peter, can you see anything on this clip? Just no extra calculations, nothing fancy. Do you see anything on here that might tell us if something's acute versus chronic?
Well, it looks like towards the top at the apex, there's a little bit of an atypical wall motion there. Oh, there's an arrow there too.
Yeah, put an arrow on there.
All right.
Yeah, so this is something called the Mcconnell sign. So the Mcconnell sign is a hyperdynamic apex or relatively hyperdynamic apex of the right ventricle with a relatively hypodynamic lateral aspect of that ventricle. So you see hypokinesis out here with hyperkinesis right at the apex. Exactly like why that happens is not really important other than to understand that it is something that it implies an acute process. And that's important, right? Nothing in medicine is 100% yes and 100% no. This implies an acute process. And that component is actually important because you can actually have a Mcconnell sign in an acute RVMI, which I've seen 2 times now in the past 6 months. You can have it in acute worsening of cor pulmonale if you have an acute worsening of pulmonary hypertension due to obstructive airways disease. The first place it was described was actually in pulmonary embolism. And so when you have a patient that has a high suspicion for PE, you do the echo, you find a Mcconnell sign that has a very high positive predictive value. However, if you look at all comers who have echoes, the Mcconnell sign is really not that specific for a PE. It's all about clinical context, but it is associated with an acute process. Is that, do you agree with that, Peter?
Yep. And I think in general, one of the really important things about recognizing a big RV in general, whether it's acute or subacute, is that if you're resuscitating a patient, and for me, if I see just a limited echo and I'm seeing a big RV, that's immediately telling me to be judicious about too much volume in a already stretched out myocardium. So I just, as I'm trying to figure out acute or subacute, it also is a real reminder to just, I think there's always easy to focus on an LV for squeeze and for LVEF and LV function, just to not to forget about that RV and get that information, and that really can influence resuscitation. So just getting a picture, seeing a large RV, absolutely great if I see the Mcconnell sign and consider it more of an acute process. But in general, just that information of how to manage the patient in front of me. It's really important.
Brilliant. And that's exactly why we do this, to get more data points. Now, one thing that I kind of struggle with is, we talk about EPSS for the LV. Do we have, surely we don't have an EPSS for the right heart, right?
We do, but spelled differently. But yeah, EPSS is one way. Ultimately, what's really nice about doing limited echo is pretty rapidly, anyone who's doing echo on a regular basis will start getting a good eyeball assessment of function. But early on, that's not so easy. And so something like EPSS for the LV function is really nice. In this case, we have TAPSE for the RV as a quick way to assess whether the right ventricle seems like it's working reasonably well, or whether it's compromised. And there's even some argument that it can be a surrogate marker for outcome, for predicting how a patient's going to do in terms of its numbers. So it's nice to know about.
Yeah, so TAPSE stands for Tricuspid Annular Plane of Systolic Excursion, and yeah, it's for the systolic function of that right heart, and it's pretty good. Like it's actually pretty easy to do, and here is like a little tutorial of doing it on the app. So this again is like a not super ideal view. This patient was respiratory distress. I'll tell you that this over here is the right heart, and this is the smaller left heart. We actually see Mcconnell sign up here, and then what you do is you click the Actions tab to get to the M mode. And then you click the M mode and you bring that cursor over to the lateral wall, kind of at the annulus there. And you'll see that M mode, by the way, is just movement along that line over time. And so you can actually measure with your line tool, you can actually measure the peak and the trough of the movement of the septum. Of the lateral annulus, and that's kind of like how you tell systolic function. It actually it's been validated to work pretty well with actual EF measurements of the right heart. Now, with this, one of the issues is what do we do with this data, right? Like, what do we do with the TAPSE measurement? And I looked it up and I struggled with it. And there's two things. The first thing is it can be used for prognosis. So if you have a patient, let's say they've started on heparin, and you want to know like what is their prognosis moving forward. TAPSE has been correlated with prognosis, meaning a low TAPSE. So the number is 1.7 centimeters for your kind of cutoff. If it's below that, it's low. If it's above that, it's normal. So you can see here, it's low. Low TAPSE is associated with poor prognosis. And I found one study, an actual emergency medicine-based study, that talks about it as far as in some patients, you might have, before you get that RV-LV ratio to be bigger, so RV bigger than the LV, the TAPSE might actually become abnormal before the RV gets super dilated. So it does have some utility, but I don't know. In my practice, for the most part, I'm really mostly looking at right heart strain rather than these other things like TAPSE. What about you, Peter? What do you think?
Agreed that, I'll be looking at one thing, just to see, looking at the annulus. I mean, the RV, different than the LV, is that linear contraction of that lateral annulus. But Again, it's always nice if there's any question or there's someone who's trying to become more proficient, then adding that measurement on as another piece of information is helpful. So eyeball works well, and sometimes putting some measurements on top of the eyeball just supports that information.
Brilliant, brilliant. Now, along the lines of this kind of stuff, Peter, this is probably like my next clip I'm going to show you is probably like one of my favorite clips I've ever like gotten in my life. Can I give you a little background before I show it to you? Is that all right? Do you have it? Do you have a second?
Sure.
All right.
I'm not going anywhere.
So I used to think I worked at a couple of different hospitals. I just moved from the University of Kentucky, where I was the ultrasound director there. I just moved to San Diego, where I now work in a hospital in a town called Temecula. I'm very happy to be back home. That's where I'm from. Now, you work in all these places, and you kind of realize that hospitals have different flows, right? I found out that the boarding problem that we had in Kentucky is also a problem that we have everywhere, right? So coming to California, I thought I'd get rid of like having to see patients in the waiting room, but unfortunately, it's like still a thing. In any case, I'm seeing a patient in the waiting room. We have no rooms to put him in. And I don't know. I just feel bad when people are waiting, and I really want to get things started. So I'm seeing this patient and they have complete normal vital signs. Luckily, they had been triaged, which is great, and normal vital signs, except for a mildly elevated respiratory rate. That was like the only abnormality. And the chief complaint was shortness of breath. Get this, the patient is a trucker, right? So the patient's a trucker. They have shortness of breath with normal vital signs and an elevated respiratory rate. So the guy is sitting, he's in the chair. He has a shirt on. I mean, we have nothing available. I'm like, let me just look. I'm not laying them down to get like good views. I'm not laying them on left out decubitus. He was literally sitting, and all you can get when they're sitting, obviously, is going to be the parasternal view. So I get a parasternal long axis view. The RV looks a little big. So I do another view called an RV inflow view, which I'll walk you through that in a second. And I see this. So just to orient everybody, we have the right atrium on the bottom right. We have the tricuspid valve in the middle, and then we have the right ventricle on the top left. Peter, what's weird about this? This is an RV inflow view.
What's weird about it is I'm getting really nervous because there's this a little bit of a hyperechoic structure that's right by the valve going between the atrium and the ventricle, which shouldn't be there.
Right. So this is a clot in transit. So this is an RV inflow view showing a clot in transit. And I'm not comparing the right side to the left side here. It doesn't matter, because if you see that clot in transit, like there's clot in there. And if the clot is wiggling back and forth in the right side of the heart, like you're seeing here, what that means is the patient already has such a significant clot burden in their lungs that this clot like doesn't have enough like pressure to go into the lungs. So there's already like a bunch of clot in the lungs. So this patient got diagnosed with a PE, clot in transit, basically within like minutes of them getting into our emergency department, which, I had the butterfly transducer in my pocket. I would have had to go back to the department, grab the machine. I was in a very small room, wasn't able to do it. And this was literally in my fanny pack. I'm sorry. I know that might shock people that I walk around with a fanny pack, but it's the easiest. I don't know. It's the easiest way to have gel and the probe ready to go. And was able to diagnose this. I mean, this is probably one of my favorite cases that I've had recently.
Case. Yeah, you can say scanny pack. That'll be less.
Scanny pack, of course, scanny pack. Now, just to orient you with like how to get this view, it's actually pretty easy. I remember when I kind of like discovered this, I was like, oh my gosh, it's so freaking easy. So you get a parasternal long. So get your best parasternal long axis view. And then when you get that parasternal long axis view, you just tilt the transducer towards the shoulder. So the beam's coming more anterior. And then boom, you're seeing all the right heart. This is right atrium. This is right ventricle. I'm going to kind of cycle it back this way. And you see what we're doing is we're basically opening up this section right here, which is the RVOT, and we get this amazing view right there, just focusing in on that right heart. We did get one question, and I want to like answer it before we move forward. Peter, is that okay if I do that real quick?
Of course.
All right. So I want you guys, I'm going to take you off screen share for just like a second. I want you guys to focus in on my phone here. And so I have it on the cardiac setting. You tap the screen. Sorry about that glare. And then you see how there's these 3 circles right here? That's how you change the setting to coherence. And it actually was a little confusing to me. So recap, this is your cardiac screen. You tap, and then you hit these 3 circles right there to change. You cycle through coherence, all the other ones. And then side note, if you hit that bottom part right there, that's actually where you can change your near gain and far gain instead of just like the overall gain, which we usually do is just like swiping one way or swiping the other way. So hopefully that answers that question. Sorry that we didn't like bring it up before. All right, let's go back to sharing. Here we go. We will do our presentation. Bingo. All right. Peter, moving on. What do we have here?
Well, this is a parasol long axis view in a cardiology convention. So you can see the marker on the screen is towards the right of the screen. And a classic parasol long is the LV is pointing towards the left side of the screen. So a really nice view. You can see a nice view of the left ventricle. The mitral valve is hitting the septum. The giblets, right? The RV outflow tract, the aortic root, and the LA are all the same size. So that portends that there's not obvious pathology. It's a little bit uphill, so that RV outflow tract is a little bit big. And then when I'm looking around, the other thing I'm seeing is that there's a tiny bit of anechoic fluid that's just below, actually circumferential. So this is a parasol long axis view where the patient has a little bit of a pericardial effusion. And you can tell it's a pericardial effusion versus pleural because down towards the bottom, that structure that's towards the right, that circle, that's a descending aorta. So a really nice marker that if that fluid is heading above the aorta or towards the top of the aorta, that's pericardial. And if it's heading below, that's pleural. The other thing here is that if you can see below that effusion, there's actually some B lines, right? There's a little hyperechoic area, which is lung. So this is pericardial. So a really nice view. One thing that I really like about the parasol long for effusions, I think the teaching, for instance, from a EFAST is that it's a subxiphoid view for fluid. But if you think about it, in a parasternal, the top is anatomically, it's the top of the screen is the sternum, and the bottom is dependent. So it's gravity dependent. So fluid flows downhill. It's a really sensitive view for seeing fluid just because it's gravity going straight down to that basal part of the heart. What's also really nice is what to do with it, right? So if it's a small amount of fluid and it's for instance, a younger patient with pleuritic chest pain, most likely something like pericarditis. But for instance, an older patient, you can also see on this view here, where I was talking about the giblets, there's aortic root. And in this case, the aortic root is normal in size. But if I see a little bit of a pericardial effusion, some atypical chest pain, and a large aortic root, I'm concerned about at least assessing for a thoracic aortic dissection because I'm getting a couple pieces of information that are really concerning when put together.
There's like, it's crazy. I mean, we have this one view, the parasternal long axis view, which is my second favorite, by the way. I definitely have favorites with views. And by the way, I totally agree with you. Apical 4 is by far my favorite view. But with this one parasternal long axis view, I mean, that is a treasure trove of information that we're getting, within a few seconds of putting gel on the transducer and putting it on the chest, which I love. So much information that we can gather from this. And a lot of it, to be honest, Peter, I mean, it's pattern recognition, right? You get a couple hundred of these echoes under your belt. And even when you don't really know exactly what's going on, you can usually kind of figure it out based off of your kind of mental model of what a normal echo should look like. And I love that. It's a good learning point, and it's a decent pericardial effusion, Now, Peter, a quick question, like, what do I do with this data? Like, let's say that somebody comes in and I don't know, they have shortness of breath. I see this echo, they're young, maybe they recently had COVID. What is something that you might think about with this? So let's say troponins are normal, like everything's fine, it's just you see this effusion around this heart.
Probably would want a little more information. So the size of the effusion, obviously if there's a big effusion and you can see a large effusion, and we're going to talk a bit about how it affects cardiac contractility, but even small effusions can be a harbinger, that they can be suggestive of some bad stuff going on. And it's important to always assess vital signs. Is this patient seem stable or unstable? But I think what's important is that sometimes the vital signs are going to lag when there be actually more significant information about the patient. So simple things are to do a different view where you can see a little more of heart wall motion, do an
Mhm.
IVC view. What is the return pressure coming in toward the RV? And if that's big or small, that's going to influence how concerned I am about the effusion that I'm seeing in front of me, especially for a younger person, right? We don't expect a younger person to have dilated fixed IVC versus more collapsible.
Yeah, no, fair enough. The reason why I bring up the code thing specifically is because I've been ultrasounding most of my COVID patients, even if they're okay or suspected COVID patients, because sometimes I uncover weird things. People will come in normal vital signs, they'll be fine, and I'll ultrasound them and I'll see beadlines everywhere. And then that to me is like, with a normal EF, normal IVC. And for me, that's like cognitive offloading. Like they very likely have COVID, right? And the other thing that I've been noticing too is that I want to say a lot, but I'm seeing it enough that it's on my radar that I will see small pericardial effusions in other people that otherwise wouldn't have pericardial effusions. And usually they have symptoms of pericarditis. And occasionally I've actually seen myocarditis present this way. So not, a significant decrease in the ejection fraction, but an effusion with elevated troponins. And that have been actually, myocarditis. That's what I'm looking for. Now, I think what you were kind of going for, Peter, was the question of, is the effusion itself causing hemodynamic compromise at all, right? Now, let's compare that with this one. This is another parasternal long axis view. Now, what's the difference between these two?
Well, other than there's a ton more fluid.
Yeah,
right?
A bunch more fluid.
Right. But one thing, just looking at the RVOT, that its motion is different from on the right side from the left side. There's something that's affecting how that RVOT is expanding and contracting in a more asymmetrical way than the left side. So concern that the pressures in that pericardial space are getting high enough to start affecting cardiac output or cardiac function because of the atypical wall motion.
Yeah, and that's huge, right? I mean, this is basically how you diagnose tamponade. This is one of like the easiest views for it. And really it has to do with collapse. Now, one of the things that I hear, and I think that there's good reasoning behind it, is to think about like just collapse in general of the RV or a trampoline sign. And those work for sure. Those work. But I hesitate with saying just trampoline sign by itself. And trampoline sign is collapse of this RV. And here's the thing, is that with tamponade, the most important thing that you're looking for is you're looking for collapse of a chamber when it's trying to fill. And that's really any chamber, to be perfectly honest. It could be, honestly, like probably the right atrium is probably the earliest marker. The reason we don't use the right atrium is because it's actually complex. It has to be great collapse, greater than 1/3 of the entire cardiac cycle. And that's a bit complex. I don't really do that. It's like an RV inversion index that you're actually looking for. So most of the time we're looking at the right ventricle and we're not looking for collapse. What we're looking for is diastolic collapse. And on this view, this parasternal long axis view, we can actually tell very easily if this is diastolic or systolic collapse. What's the trick, Peter, to know if it's diastolic or systolic collapse?
My favorite trick is just freezing the image and rotating back and forth till I see the valve closed or valve open. And then I can really be confident that I'm seeing diastole or systole. And then you're, in this case, that's down works well.
Yeah, no, I like your kid. Now I like to slow these down, but like in real life, like you can't really like slow it down. Like you can't go, this is a quarter speed over here. You can't really go quarter speed. But what Peter does and what I suggest too is you actually freeze it and look to see when that valve is open. So the mitral valve and the tricuspid valve open up at the same time, right? Essentially. So if the mitral valve is open right here, it's open. If you see collapse of the RV free wall up top when the valve is open, that means that is diastolic collapse. Diastolic collapse is sonographic tamponade. Now, one thing that I don't know, I feel kind of strongly about is the idea that tamponade is a clinical diagnosis. I see what most people are saying with regards to this. Like I get it. But here's the problem. The problem is that if we wait until the vital signs are unstable before we call it tamponade, I worry that we're waiting to do something about it until the patient has lost all their compensatory mechanisms. I mean, if you look at cardiology's literature, this is like cath lab diagnosed tamponade. Most of them are actually normotensive or hypertensive, because what happens when you're in shock, you're early shock, your body's going to shoot out epinephrine, which is going to artificially increase your blood pressure, right? Artificially increase your heart rate. So just be very careful, I would suggest, in saying that a patient who's clearly in tamponade sonographically is not in tamponade because their vital signs are unstable. Hopefully that's not too controversial, but it just makes sense physiologically to me. Peter, what are your thoughts on it?
Well, we're talking about an entire spectrum, right? So you have the patient coming in, maybe a youngish patient with chest pain, has a little bit of pericardial fluid with or without associating with whatever infection they've had. And you can talk about that potentially being a pericarditis. Certainly that spectrum includes a troponin, because if that's positive and you have a perimyo, that's a different disposition. But once there's any question of significant fluid or any type of cardiac dysfunction, that's tamponade. And I don't care what the vital signs are. It's also effective how there's disposition. It's much more pleasant for the whole patient experience to go to a cath lab electively versus having to do an emergent procedure. So unfortunately, the end result of not recognizing tamponade early enough and managing it early enough is that we get to play with our ultrasound at the bedside and do procedures, which is, there's something that's nice about doing procedures, but not when someone who's dying. For instance, in this case, I was looking at this, and this is a parasternal long axis view. And what's, when, for instance, when people talk about doing a pericardiocentesis, right, this is a perfect view to do a needle if you needed it, because if you look at the fluid, it's only 3 centimeters down from the chest wall. So an easy target to go with that same transducer and put a needle in. My preference would be to have that happen in an organized way in the cath lab if the patient's vital signs would tolerate it. And there's always a little room in someone who's has tamponade to add a little volume, even though that seems counterintuitive, to support the pressure and have it done in a controlled place versus when the patient is crashing in front of. So completely agree that I think you and I probably have both had conversations with consultants who argued that because the patient had normal vital signs, they didn't need to be urgent or emergent about catheterization. Once I'm seeing any type of change in pressure in the pericardium and the myocardium, I'm going to be pretty aggressive about trying to have somebody manage that patient relatively quickly.
Yeah, great point. I mean, I love stabbing patients, right? I mean, I love nerve blocks. I actually lately I've been doing a lot of arthrocentesis, and patients, like, they get so much relief from it. I want to alleviate suffering. It often happens at the end of a large, needle, but pericardiocentesis honestly is like one of my favorite procedures, but I would rather it be done by someone in a controlled environment. I agree with you. Someone who has done thousands of these or hundreds or thousands of these pericardiocentesis, they should be the ones that are doing these. I'll pitch in if I need to, and I like to, but it should be done in a controlled environment. And that's one of the powers, the superpower that ultrasound has, is that you can actually find this potentially hours before they crash, which that's when I want to find it, Peter. I don't want to find it when they're crashing. I want to find it hours before, like that PE, right? That PE with normal vital signs that I showed you earlier. I mean, he would have gotten the CT. Undoubtedly, he would have gotten a CT, because I probably would have gotten a D-dimer. The D-dimer would have been positive, and then I would have had to wait for the creatinine, and then I would have had to wait for radiology to do the scan. It would have happened, but I've uncovered it, 2 to 3 hours before with a normal flow of how things were that day. But instead I found it instantaneously. And it's the same thing with these pericarditis.
And there's a chance, there's lots of association with cardiac arrest with PE. So potentially he could have been sitting in the waiting room, and while he was waiting for his triage and for his eventual D-dimer and CT scan, had his cardiac arrest in the waiting room, and it's similar. Yes, pericardiocentesis is really, I guess it's a really satisfying procedure, because when I've had to do it, it's been on crashing patients. And after I get 60 cc's out of the pericardial fluid, they actually have a pulse and are alive. But I was going to say, favorite to me is not when the patient's dying in front of me. So the more I can have this done in an elective way, where I'm not having even the stressor of, if this doesn't work, this is not a good thing, I'd pick a nice nerve block as favorite and a little more calm.
Yeah, agreed.
But
now this one I just
satisfying when you get vital signs back and there's that bunch of fluid in your syringe.
Yeah, and it's one of those things that's like, man, I just think about like what would happen if we didn't do this or did do this. Like we never know what the right like course of action is often right when we're doing it, but diagnosing somebody with tamponade very, very likely is going to dramatically improve their outcome, especially if we find it beforehand. Now,
Right.
this clip here, this is just for fun. I mean, this is actually a different patient with tamponade. I love this because it really shows that EKG finding that we talk about, right, Peter? Like this is what electrical alternance looks like. You can see it's like waving around in that fluid. I don't know. Would you even have a discussion of is this tamponade or not on this specific apical 4?
I would. Or you can, I mean, again, there's a question of chronic versus acute. And so you can see patients who have huge pericardial effusions and they have electric alternance. And it's really fun to be able to correlate what that, I remember learning about that in medical school and looking at the squiggly lines on a piece of paper. It's really fun to correlate that with an ultrasound and actually understand what that means in terms of physiology and anatomy. But again, slowing the clip down or stopping and looking at valves and looking what the ventricles are doing with valve closure, just as much as it's important to be aggressive or relatively prudent about pulling off fluid for a patient who is in early tamponade or in tamponade. People have chronic pericardial effusions and are stable and don't have any tamponade physiology. It's going to back off a little bit. And it's amazing when you see how much fluid people run around with in their life. They show up and have pericardial effusions that have probably been there for months and they're enormous and don't need that emergent needle. So I think always good to back up and slow down the clip, stop the clip, look at the valves and make a decision. Is there diastolic collapse or not? And if there is, absolutely you move in that direction. If there's not, that's a different decision node.
Yeah, no, fair enough. I will say on this view, how I just kind of like mentioned that I love the apical 4 is my favorite view. This is one of the times, and this is especially true in like an elderly patient. And I only say that because they often have a little more of a pericardial fat pad. This is the one time that like the apical 4 is not my favorite because I feel like due to edge artifact and due to, just like fat on the edge of the heart here, I just feel like I can't really get good views of if the right heart is actually collapsing or not. I feel like I can usually see the free wall of the atrium, but I really struggle with the free wall of the RV on the apical 4. So I'm usually going parasternal for tamponade or subxiphoid.
Agree. And that's the point, right?
Now,
that's one of the reasons there are all these different pericardial views is that if you have one that doesn't answer the question, get a different view and be more confident in the answer.
Peter, what happens? Let's take this case right here, right? Let's say this is the only view. Let's say that they have, I don't know, they have like 2 pacemakers on the left side of their chest or something. There's some reason why you can't get a parasternal view. They are very rotund. You can't get a subxiphoid view. This is the only view you can get. And let's say they have soft vital signs, right? They have a heart rate of, let's just say like 102. They have blood pressure of like 105 systolic. Like it's all borderline, mildly elevated respiratory rate. Is there like another piece of data that we can obtain with ultrasound to help us know if this is tamponade or not?
Just always look at that IVC.
Oh yeah.
See what those.
Yeah, that IVC is a great, and most of the time when I have pericardial effusions, I am looking at the IVC, almost irrespective of if I'm like, I definitely see collapse or not, but it's especially helpful in these borderline situations. Now, the IVC is this long kind of stringy thing, and we're seeing here let's look on the right side first, this IVC right here, it's collapsing a little bit maybe, but it's definitely less than 50%, and it's pretty plump. And the same thing over here. Now, this one is collapsing almost nothing, and it's very plump as well. Now, this one, you can actually see the tamponade. Like you see a flickery thing in here, and you see fluid up here. Now, Peter, why is one up and one on the left and one on the right?
Well, I think somebody by inadvertently pushed the abdominal setting versus the cardiac setting or vice versa. So, again, depending on which setting you've chosen, whether by accident or not, it's going to affect orientation. And the point is to understand the structures that are being looked at or not. I personally I will always, independent of my marker, I'll just flip my transducer. I like to get the same orientation every time I look at structures. I think there's less chance for error if I'm cognitively flipping things over in my brain, trying to say, okay, if I had this over on the right side, it would look I'd be more familiar with it. So I'll just flip it over to get the image the way I'm used to looking at it. And I feel like there's a little less chance for missing something, for making an error. But either way, the idea is recognizing the structures and understanding what to do with what's in front of you. So in this case, because the markers are flipped by settings, the IVC is on a different side. But there's still both IVCs, and they still both are plump, and one clearly not having that respiratory variation.
Yeah, and Peter, I mean, this is one of those things where like we have to always make sure to take everything together. Like the ultrasound oftentimes is like the truth, right? It's the truth. But it needs to be used in conjunction with you as a clinician, like what you've developed over your course of whatever school training you've had, whether you're an MD, a nurse, whatever. Your experience as a clinician, because we all know that med school or nursing school or any other grad school is not necessarily the same as practicing on actual patients and having to see these things in real life and understand that patients don't follow textbooks. Like they're going to do whatever they want. The patient's body is going to do whatever it feels like doing, and sometimes it doesn't match up. And being able to take the ultrasound, the patient's presenting complaint, how they look, and then other things like the IVC, for instance, are really helpful. I think, kind of a tangent side note, like one of the things that I think about a lot is COVID, right? I feel like COVID is kind of like it's kind of thrown B-lines, for instance, a bit of a loop, because it used to be someone comes in shortness of breath, you see B-lines, it's heart failure every time. But now with COVID, that's how it presents. Like, yeah, we do that. But we also like, do they have a fever? Do they have exposure? Are they vaccinated? Like those are all actually important things. Plus, now, even more than ever, I'm tacking on an IVC and an echo before I'm actually saying like, this is definitely heart failure or this is not. So, I mean, it all has to like come together. Clues, tool in your quiver or arrow in your toolbox, right? I mean, it's something to help you out to figure out what's the best thing to do for your patients.
Right. But again, the reason we do this and the power of this is that you're a clinician at the bedside. You're always going to be a clinician, and you try and use the best data that you have to take care of the patient in front of you. And the power of taking an IQ and going up to the patient that I'm seeing is I can say, I have an idea about what this may do. Let me take a look. And sometimes I get the answer exactly. And just as you had that case of the trucker, we can describe, like we spend the whole evening talking about cases where a presentation was benign and I put a transducer on somebody's chest or belly or leg, and I'm surprised by what I see, and I'm making a change in that management based on that quick look. So the idea, the power of being able to make a decision with a little more information at the bedside is really what, for me, drives us home, is that I get to have a little more information early on. I can change management or not. I think that's back to that humility of having a tool in the quiver or an arrow in the toolbox, where sometimes I need something else and I don't have the answer, but that's okay. That's part of how medicine happens and how we progress in our patient care.
Peter, do you think we have time for one more? I'm kind of like debating, like we can do one more clip. Do you think? I think we have time. We should do just one. We just do one more. Yeah. All right. Let's do one more. So let me give you a case here. We have a 35-year-old male, found down, has chest compressions, and then arrives at your ER. You do one round of CPR, and on the pulse check, you see this. What do you think? Should we just call the code now?
Absolutely not. If this is a young person, right? So there's so many things that the ultrasound can be helpful for in this situation. So first, there's about identification of cardiac stencil. So resume CPR immediately to stop looking at that image, and then start doing things potentially to help that person have a chance of a better outcome. So yeah. I think there definitely is there's controversy about when do you truly call something cardiac stencil. For a single look and a single bunch of resuscitation, I wouldn't stop yet.
Yeah, and this is huge, right? I mean, it's the reason why, like, you can't just like look at an abstract and just be like, I just read the abstract, so I'm just going to like follow what this abstract says. Because if you look at some of the data, it does say that if there's cardiac stencil, which, I mean, this is not full cardiac stencil. We see a little, like an ejection fraction of like 0.5 over here, but this is like a very bad looking heart, right? We have the little bubbles from the saline over here. Yeah, it looks bad, but just because you look at all comers and all comers are, like this, that doesn't mean that this person's going to do bad. And this is, again, history and what you think as a clinician. Now, let me show you what happened 2 rounds later. Pretty good, right? So good. Just to kind of orient you, and this is like real life, right? This is a subxiphoid view. We have the left side of the heart over here, right side of the heart over here. And this, I'm pretty sure, was a backwards, like apical 4 maybe, or maybe it was a weird subxiphoid, but this it looks like it's a weird subxiphoid. So that was, the pro marker was flipped. So this is the right side of the heart, this is the left side of the heart, and this is real life, you guys, right? This is like how things happen. And we're actually seeing some motion, like a good enough ejection fraction to move things forward. So we were able to kind of figure this out. And I'm glad that, Peter, I'm glad that we didn't stop just because the initial echo looked so bad, right? We kept going. We could have, Peter and I have a lot of ideas, and I feel like they mostly match up, if not completely match up, with how to do ultrasound and cardiac arrest. And Peter, since we are wrapping up here, can you give one, we could have a whole hour-long discussion on how to use ultrasound and cardiac arrest, but can you give us like one thing that you want us to think about when using ultrasound during cardiac arrest?
Well, I'll do 2 since I have the opportunity. One is to don't let the ultrasound interrupt good CPR, right? That's one of the concerns. And so be judicious. So if you're going to get ready to put a probe on, have the gel on, have the rag to wipe it off, have someone time it, get that probe on. What I like to do, the thing that I really like about using ultrasound for cardiac arrest is I like to get an apical 4 chamber view, even as CPR is in progress. See if I can get that, because I can do a couple things. One is that when there's a cessation of CPR, I can really get a nice view quickly, push my button of record and have the person start right away. But the other is that I like to try and adjust the hand position to get better left ventricular squeeze, because when somebody has mid-sternal CPR, that ventricle sometimes not compressing. If I can get an apical 4, I will actually have the operator slide their hand over towards the left side, usually, where I'll see that ventricle compressing a little bit more. And I don't know if that was this case, but we all have these case reports or case stories of having adjusted LV compression by hand position, and the next pulse check is ROSC. And here's a case of someone who's young and healthy, the decision not to stop CPR and to do a couple rounds with maybe some ultrasound assistance for hand position, and now this person has a functioning heart and potentially a good outcome.
Brilliant. No, those are good points. Your points are points that I lecture on when I'm talking about ultrasound and cardiac arrest. Now, I guess you stole mine, Peter, so thank you for stealing mine. But I guess my framework for thinking about ultrasound and cardiac arrest is the following. Like, you use it for basically 3 things. You use it for procedural, use it for identifying reversible causes, and you use it for guiding your resuscitation, basically. So pulse checks. And I think that's a good way of like thinking about it. And obviously the procedural, and then the identifying reversible causes, that's something you can actually do during chest compressions and won't get in the way. And then using it during pulse checks is good as well. Now, we did have a question here, and it's a good question, Peter. I'm going to stop the screen share here so we can just like focus on our faces here. Now, the question is, we have somebody who is, working out in the field. Okay. And the question is, how would they utilize these ultrasounds to either call a code or not, which is kind of like intense, right? To like call a code when you're out in the field. I'll give my thoughts. Now, I'll disclaimer this with me, I'm not an EMS person. I've only been in an ambulance as a patient. So I go in the back of ambulances sometimes at work, because like we have rows of ambulances outside, and I'm not going to wait for someone to get rolled in. So I've been in the back of an ambulance. And by the way, what our EMS colleagues do is phenomenal. I get stressed out sometimes working in a crowded ER room, and there are 2 people working in the back of a van. It's intense, so much respect. And being in the field, like having to manage people in cars and stuff, it's amazing that there are people that are trained and good at that. But my thought is the following. Now we, and this is like a whole nother, like this is a whole branch of intra-arrest echo. We are actually very bad at pulse checks. So there's plenty of data that shows that we are not good at telling when a patient does or does not have a pulse. So the way that I imagine it is I imagine it to basically confirm that you don't feel a pulse is what I would think about it. And this is, of course, going to be different if you have a young person that has a really good prognosis versus a nursing home patient that both legs are amputated and has cancer, right? These are two completely different patient populations. You always have to keep that in mind. But if you've gone through a couple, they say they were found down, you don't know how long they've been down, and you don't feel a pulse, you do your echo, and your echo is basically no movement, I'd be pretty comfortable at that point, assuming that, unknown downtime, poor prognosis. I'd be pretty comfortable saying, like, I think that at this point, the chance of neurologic recovery in this patient is exceedingly low. Whereas let's say we have the same patient, I don't feel a pulse, and then I do the echo and I see cardiac activity, then I might actually either keep going or assume that the patient actually does have a pulse, but I can't feel the pulse as well as I think I can. What do you think, Peter?
Yeah, that's pseudo PE, right? So I completely agree. The literature on pulse checks is really sober. Like we're not as good as we think we are. And the fact that we have a device now that gives a little more of that information, I think terminating is a hard decision. But
very hard.
As you were describing, if especially I live in an area we have long transport times. We have ambulances that are coming in with an hour of transport. That's an hour of CPR in the field, which is heroic.
Oh my gosh, that's crazy.
But so I think in that regard, if everything is done well, there's been good CPR, you've looked for an alternative diagnosis, just a hand position, and there's still cardiac standstill. I think in the context of having medical direction or protocols about when to terminate, that's information that's useful to make that decision. And how many times have I been involved in a case that there's been no pulse, CPR is in progress, put the transducer on, and there's actually cardiac activity. Okay, now changes management and changes how to think about it. But that's certainly someone you're going to be aggressive with to try and keep on resuscitating. So just a little more power, again, in terms of answer those questions. There's one more question, Jacob, that's on about whether it's worth it to do a cardiac ultrasound for even general screening. So I think probably have the same strong opinions on this, but I'll defer to your thoughts on that.
My thought is it obviously everything depends, but I'm not sure what the downside is to just like, even if someone's asymptomatic, they've never had an echo before, just looking. I mean, there's plenty of data that shows that if you do this on athletes, for instance, like asymptomatic athletes, you will uncover that hypertrophic septum of the LV, and you might actually save them from dying. And let's say that you scan, 500 people and you find one. Like, I don't know. I know from a grand scheme of things that might not be like worth it, but to me it is. And what if my kid was that 1 out of 500 that you happen to find this, right? Like, great. Correct. And then if you have like an older person that has never had an ultrasound before, you do it and you find out that they have like significant aortic stenosis. Great. Like, you found it early, like I don't know what the downside is what I'm trying to say. What are your thoughts, Peter?
Yeah, completely agree. Again, lung and heart, right? The routine is for a normal exam is you listen with the stethoscope. I personally like seeing the picture. I get more information, and it's true. Most of those are negative studies, right? Most EFAS are negative, but every once in a while you see something which is positive, and it's that piece of information that can change a total outcome by being recognized early. So absolutely, why not use it?
I agree 100%. Peter, we didn't do a whole series of slides, and so this is great. Peter, thanks so much. Oh my gosh, for like being on here with us and like being so good at what you do and how you discuss things. I'm very thankful for your insight on emergency medicine, on just like life, by the way, and then ultrasound.
Well, that's
in
the next
general.
Webinar is just a life discussion. Just
life decisions. Thank you so much, everybody, for joining. This is I'm not going to read the slide, but here's the information. We would love to hear from you. And honestly, good things and bad things, you know what I mean? Like it's fine. We want to make this a good experience. And it's hard for us to know if it's a good experience if we don't hear from you guys. I mean, this was a good experience for me. I love talking
Yeah.
with Peter.
Yeah.
But yeah, let us know. Image review at butterflynetinc.com. We're going to be doing this longitudinally. I mean, I don't know, indefinitely. So stay tuned for the next image review seminar. We'll keep you posted. Thank you, everybody.
Yeah. Thank you all. Thank you, Jacob.